give the microphone to my predecessor, or honorary member, Ute Valentin.
Thank you very much. And I don't want to lose any further words because we are behind schedule already.
Yes, and our first presentation will be made by Professor Audun Stubhaug, Professor of Anesthesiology and Pain Medicine at the University of Oslo.
Thank you very much for this large and challenging title. I thought it would suit to have a picture from our department saying that we can't make everything, we can't make an elephant jump, but I say for sure the white elephant can make you fly. So that means that wonderful things can happen, even if not always all we want. What's the definition of pain? The International Association for the Study of Pain have recently updated the definition, and it's now meant to cover all kind of pain. Pain in speaking humans, in children, in non-speaking human beings, and also in animals. So it's defined as an unpleasant sensory and emotional experience. So it's both sensory and emotional, associated with or resembling that associated with actual or potential tissue damage. And it's also explained that it's a personal experience that should be respected as described by the person, and it is influenced to varying degrees both by biological, psychological and social factors. There are translations available on the ISP homepage, and we have just finished the Norwegian translation, which will be launched in a meeting next week. So all translations that are official are available at the isppain.org. All people have a kind of a relation to pain because that's something we learn earlier in life and teach us how to adapt to the environment. And people may have different concepts of pain. Normally, pain has a good role and serves adaptive. However, when pain lasts for a long time, we don't need pain there to remind us about it anymore. It's at that time it often serves negative effects, and it very often has negative effect on function, social life, and psychological well-being. In pain physiology, I have two things I try to teach my medical students. And that is the concept of plasticity and the enormous individual variation we see between subjects. And first to the individual variation. This is an experiment from in our lab where we stimulate the arm with heat, and you see from 42 degrees to 50 degrees in this case, and then the subjects score how much pain they feel. And under this very controlled situation with healthy people, you see it's an enormous variation, so that some people have extraordinary pain already at 40, 45, 46 degrees, while others feel nothing when we have to stop because we don't want to make a burn injury. And in the clinical situation, I like to show this picture because it's from a surgical population. It's from Denmark, and it's about the pain the 7 days after cholecystectomy, which is a very standardized operation, and all receive standard drug. And unlike most articles, they don't present it with a mean, a bar, and a small error bar. They present each patient separately as a dot. And as you see here, after 6 hours, some people have no pain at all, while others have the maximum pain they can describe. after a standardized operation, a standardized treatment. And that means that these people down here, anything you do for them only will give side effects. No, they don't need anything. While here you will have to maybe really add a number of things together. What about plasticity? Many of you, at least those of you who have a light skin, have experienced sunburn. If you fall asleep in May at the beach in Spain, and after 2 hours, the nervous system has changed so that when previously the close touch was just it was a touch and it was comfortable, and now it's suddenly painful. So the comfortable touch has become painful, and that happens also around all injuries, after all fractures. It gets painful around the injury. And not only that, also our genes, we have our genetic imprint, but most genes, they are not active. So, but after an injury, suddenly genes can be expressed differently, so that the nerves, for example, after a nerve injury, can suddenly contain different sodium channels, and the nerve can start to signal spontaneously without any reason at all. I'll show a picture of that from a few cases. Pain can be classified in very many ways. I think the upper here is very important: acute versus chronic pain versus cancer-related pain. And it can also be classified, you will hear more about that today, I think, on nociceptive, neuropathic, and nociplastic, which is a mechanism, or due to the intensity, mild, moderate, strong, how much it affects life and distress. And we can, in addition to that, we have started using a diagnosis system called ICD-11. First, to the difference between acute pain, cancer-related pain, and chronic pain. This is also something I teach my medical students all the time, because they have to be aware of the huge difference. Acute pain has normally a good role, adaptive role, and very often we are interested in reducing the pain intensity, and we want to do that in order to promote mobilization. How quickly can we remove acute pain? Well, give me a minute and we can do it. In the operation theater, we can do it in a minute. We have an IV needle, and the quickest opioids work in 1 minute. So that's possible. We don't look a lot ahead, so we are not afraid of giving a lot of drugs, because we usually have antidotes, and as long as we don't leave the patient alone, we can control respiratory depression, bleeding, sedation in a nice way. And we also have the means at hand to reduce it. When it comes to cancer, it's a famous Norwegian doctor who joked about himself, said that I am the Norwegian man who has been dying for a longest period. Over 10 years I have been dying. But that was Per Fugelli, and when he joked about that, I thought I could bring that joke further as well. But he said very importantly that for me, it's my personal, individual wishes that are important for me, and that means I want to go to the island in the north where I had my first service. I want next summer to take my whole family to Rome. And if that is the most important thing, then of course the means we use also has to adapt and be not as important. So then we wouldn't use drugs that are sedative, drugs that takes away cognitive function and so on, and we would not use maybe pumps and things like that. And what most people are interested in avoiding is nausea, anorexia, and a loss of cognitive function. With chronic pain, I usually took away pain intensity because I said that's not important to focus on. But I put it back in brackets now after having had a lot of complaints from other doctors. And since Food and Drug Administration and EMA also evaluate pain intensity in chronic pain conditions. But better function and quality of life is important, and I will show the time perspective may be years or decades. And that means that rare or side effects like cerebrovascular side effects, hormone affection, cognitive function, and dependency are important side effects. And that means who believes one solution fits all? It's not possible. We have to decide what are we treating. The pain population is changing. WHO did an initiative, the Global Burden of Diseases, Injuries and Risk Factors. It started in 2010, it's still ongoing. And we have people in the Scandinavian country who deliver data for this global office every year. And I'll show you a few pictures. WHO, they focused on death and to reduce early deaths. And as you see here, this is from Western Europe. You see that the blue, cancer, and the dark blue, cardiovascular disease, they take most lives, but they do it late in life. When WHO started to also focus on disability, not only on life, the picture changed completely. See here, cancer means nothing. Cardiovascular disease means a little bit, but late in life. While mental diseases, like could be schizophrenia, depression, anxiety, and musculoskeletal diseases and injuries means tremendously more, and from early in life. And that means that we have to take really understand that some may even have the disease from early life and through the lifespan, and that puts enormous. It makes it very important to have kind of to have treatment that can be working for a long time. So there are 3 pillars in evidence-based medicine, especially in pain medicine as well. And people like to say that we practice evidence-based medicine, and they believe very often that it's evidence. Evidence is evidence-based medicine. But that's only one of the pillars. And for small diseases, for rare diseases, we hardly have any evidence. So best current evidence may be very little. But then I have to say that, but we have the 2 other pillars, and one of them is the clinical expertise, which you can use without evidence. And then the 3rd pillar, which most doctors have never heard about, it's the patient's preferences and values. This is true. This is true. But it's the patient's preference as well. So I'll take you through this now, how pain can be treated according to these principles and the evidence. I don't mention it. That's for other lectures. What about clinical expertise? Can that add something? Now I'll show you an example. This is a man with had herpes zoster and postherpetic neuralgia. He has tremendously allodynia. You cannot touch him here. He is oversensitive to touch, to heat, to cold, and the next patient I had with the same disease in the same area, he had no allodynia, no hypersensitivity at all. I could do like this. He was anesthetic. So that means that the disease doesn't mean that the treatment should be the same. This guy can have local treatment on the skin. The other guy needs drugs that works in the brain. That's how a good clinical examination can help aid you. And the next patient is from a woman with breast cancer. And I showed this just to show that the same subject can, in the same area, have different types of pain that need different solutions. She has here a nerve injury, and she has spontaneous burning pain in all the red area, also including the hypoesthetic area here, where she has a complete differentiation. In addition to that, she has allodynia, and she also has a trigger area with spontaneous active, probably sodium channels. And that means there are 3 different neuropathic pain mechanisms in the same subject. So we can, the expert can discuss this with the patient. You can ask, how does it work on this pain? How does it work on that pain? And yeah. What about then the patient's preferences and values? Well, if we want to know, to address that, we need to know a lot about those we treat. So that's why normally in a multidisciplinary pain clinic, we will talk more about that tomorrow, we have to know all this from each subject, all about the pain history and the severity, the quality of life, the physical, the function, the bodily symptoms from the rest of the body, sleep, coping, and expectations. What are the wishes? What are the priority for each subject? So, why did we want to implement a new classification system? It's because classification due to mechanism is one thing, but the pain diagnosis is something different. What we want is that all who come to a clinic shall come out of it with a kind of a clear diagnosis, so that we can learn how to treat the different types of pain. So I'll show you this here. ICD-11 briefly. It's 7 main categories: primary pain, and it's secondary chronic cancer-related pain, post-surgical or post-traumatic pain, chronic neuropathic pain, secondary headache and orofacial pain, and secondary visceral pain, and secondary musculoskeletal pain. So we classify this very easily by pull-down menus, like you see here down here. Click, and then you click second level, and then you click a possible ICD-10 diagnosis. Very quickly done. And now I'll show you an example of one patient who kind of benefits from this. Female woman, 50 years, painful neuropathy after immunotherapy. That's quite common now. A lot of cancer survivors have these kind of problems. If we should use a normal classification system, we would probably call it malignant melanoma, but that need not be painful at all. Malignant melanoma can just be a history, a pain history, a cancer history. Or we could call it drug-induced polyneuropathy, which is also in a normal system, but drug-induced polyneuropathy need not be painful. That can be only numbness and tingling. So what we do in the ICD-11 is that the pain itself gets a diagnosis. So it's a chronic pain diagnosis system. So in this case, we could call it chronic cancer-related pain with a subclassification. We could call it chronic neuropathic pain with a subclassification. And we could score it with severity on pain, distress, and functional impairment. So here are the numbers from the 2,354 first patients in our clinic. You see that we have quite a lot of primary pain, quite a lot of neuropathic pain, post-surgical, post-traumatic pain, and also quite a lot of secondary musculoskeletal pain. Very few cancer patients, they are treated at cancer hospitals. So the 3 pillars, what the expertise, what we can do with expertise, I did show that. What about the patient preferences and values? That can be quite difficult for a doctor to kind of adapt to, because we might have different opinions Yeah. So I'll show you now one short case, just to show you that it can be very difficult, but there are solutions. This is a case that is a combined male-female patient, 26 years old. Here is the picture from the first consultation, and I usually find 5 errors, and since the audience is so big, I have to show the one error is the protective arm. It's not in use, has not been in use for several years. It's so painful, so the nail has not been cut. It's a abnormality of sweating, as you see, both on the finger and on the whole half of the body, and the reason is this small injury. So that's a very severe complex regional pain syndrome, and during the last 10 years, it has been going up and down with a lot of different treatments. There we have them. A lot of drugs, a lot of invasive treatments with pumps and spinal cord stimulation, and now it's a crisis. After a good education, higher education, the first job, the stress is too much, everything is worse. It's attacks of pain with fainting, poor sleep, hospitalized in a ward, high doses of opioids, and the family is afraid of suicide, and the doctors are afraid of overdose. So what should we do? What can we do? Hasn't everything been done already? No. What wasn't done? What we said we need to talk together. We have to. Maybe we don't have different opinions on what to do. So we said we needed a long discussion with you and the family. So we had a 2-hour discussion, and then I said we have some conditions. And at this time, and this is the patient preferences and values, they changed during those 2 hours. We had a new understanding together. We had the same understanding that we should focus on job, family, how can maybe reduce the job a little bit lower ambitions. It's not about OI in particular. No. So this is because of the heavy burden. So that was happening, and what do you think? The result was that the patient was motivated for a change, and we could reach a combined solution, and the result is to get back the control of life and the future. Maybe not rid of all the pain, but control of life. So thank you very much.